I welcome our next speaker. It is Anne from Norway. Where are you? Here, please come to me. She's an expert in donor milk banking. She's the medical director of the Oslo Milk Bank, a founder member of EMBA, the European Milk Bank Association, and you were our secretary for lots of years, too many years, okay. And you also give your advice to milk banks, for example, in India. Anne ist eine Milchbankdirektorin aus Oslo in Norwegen. Sie hat viele Jahre in der EMBA gearbeitet, kümmert sich um den Aufbau von Milchbanken in Indien. Und was ganz besonders ist, ganz Norwegen füttert rohe Spenderinnenmilch seit über 70 Jahren wahrscheinlich. So you will talk to us about your decades of experience in using raw milk in Norway. Thank you.
So this is a hospital in Oslo. You already gave me a good presentation. So I'm a breastfeeding consultant and a multicultural healthcare consultant. And since I've been working in India for 10 years, that's very helpful. So we have quite a good breastfeeding rate in Norway, but still there are room for improvements. Although 78% are breastfeeding at 6 months, they are not following the advice to fully breastfeed. Too many use mixed feed too early. Also, many describes that early discharge from the maternity unit makes it difficult to get the help you need when you need it. The peer support group Ammehjelpen, which is an organization of mothers that help other mothers for free, they have too many inquiries. But we do see more mothers that breastfeed for a long term. Up to 2-3 years is normal. Or paid long parental leave is supported when it comes to breastfeeding. But now it is described that the equality between mothers and fathers is a hindrance for some to continue to breastfeed. Even in a very breastfeeding friendly country, fathers cannot breastfeed. If you fail to produce enough milk, or if the mother died, there was few opportunities to raise the little ones without a benevolent soul who made herself available. This was a girl who had a child herself, perhaps lost a child, or who had plenty of milk. She was employed to take care of this somewhat unsightly task, while the ladies could continue with their morning visits and sumptuous dinners. King Louis XIV, who called himself the Sun King, of course had a wet nose. The dominant thought about breastfeeding was that it was immoral, indecent, that it destroyed the breast, and it was described as foolish. Many solutions was tried out to feed the babies. And you see the attempt with the goat for little baby. And then you have the Krankenschwesters at work. And this can be said to be the first milk bank. It was milk from other mothers feeding babies. So our first milk bank was opened by who, do you think? It was by the Germans in 1941. Not sure what they were doing in Norway at that time, but at least they opened the milk bank. And the milk bank that I'm working now is the remains of that milk bank. And it has been running constantly since it was opened by you. So the first guideline came in 2002, and we had a drop from 18 to 30 milk banks. And that was due to the more time-consuming procedures in the guidelines. And now we have 12 milk banks. We have had new guidelines in 2019, and we have 20 NICUs 11 of these have preterm babies less than 26 weeks, and 6 facilities have preterms from week 23. A few milk banks sell milk to the other hospitals, so that all preterm babies in Norway are offered milk from a bank if needed. All the donors are tested and interviewed and screened and must be healthy. A blood test is taken every 3rd month. CMV negative donors are tested more often. We do allow donations up to the donor's own infant is 1 year of age. But most of the donors donate up to the point where they go back to work. It is a very healthy population in Norway, and we do not find a lot of hepatitis or HIV among potential donors. Most of the donors are mothers of healthy babies staying at home, but also we have some mothers from the NICU patients or surgical patients. We usually have no problems with having enough milk in the bank. But in my bank, which is the largest one, we are located in the densest populated area in Norway. And some of the smaller milk banks do have problems to get enough donors sometimes. But we are a small country and a close community, so we always help each other out. So no babies or preterm babies are left without milk. So this was during the COVID, so we were not allowed to bring donors inside, so we met them outside the hospital. We have around 400 donors each year in Norway. They donate approximately 4,000 liters. Some donate less than a liter and some up to 400 liters. And many of our donors come back when they have a new child. And one donor has donated 5 times. She says that this will be the last one, but who knows? All the boxes or bottles are tested for bacterial content. When we take the test, we do the scraping as described yesterday, or we defrost it a little bit so it gets thawed on the side, and we take the test. And how long we have to leave it out depends on the temperature in the room and how many containers we are processing. It is important to get a sample that gives us milk from every layer in the box, but usually there's only one pumping in each box. So we've all heard about the new system that has been developed, and we are eager to try it out in full scale. So far, we have just participated in the pre-testing of it. And for the raw milk, we allow up to 10,000 CFU per ml. We do not allow any pathogens, potential pathogens in the milk. Milk contaminated with pathogens is destroyed or returned to the donor if she wants to have it back. We also contribute to some research projects, and this milk that cannot be used in the milk bank can be used for research. Approximately half of all the milk we receive is being used raw. And this we learned from you. We've just been continuing to do what we started to do in 1941. As I pointed out, it should not contain any pathogens. And some of the milk that does not meet the criteria to be used raw, that can be pasteurized. And there is risk and benefits associated with using raw milk. We are constantly discussing it, and who knows what the future will bring. The risks are obvious. Our milk bank routines exclude a lot of different risk behavior, but we can have a failure, either human failure or a failure in the blood test, and milk with viruses may be transferred. But this has never happened though. The benefits, on the other hand, are also great. Heat treatment of the milk will lead to an inactivation of some of the active components. We believe that our positive experience with this during the last 80 years support our ongoing practice. We do have a low occurrence of necrotizing enterocolitis and late onset sepsis. However, we do not know enough about this to say if it's the full enteral feeding or if it's the use of raw milk that has this effect. Probably are both important to reach as good outcome as possible. All CMV negative, CMV IgG negative donors are screened for every donation, which is typically once a month. We also screen them for CMV IgM and PCR. Milk from CMV positive donors are used for infants larger than 1,500 grams. And they have to repeat the regular blood test every third month. And the blood test can be taken either at the hospital or at the donor's regular primary care facility. Sick and preterm infants are offered mothers who cannot be fed mother's own milk for the first days. If the mother is sick or doesn't have enough milk yet, they are fed donor milk. Formula will be given before discharge if the mother still is not producing enough milk. We also feed pre- and post-operative infants if there's no mother's milk available. The use of donor milk should be a bridge to breastfeeding, not a substitute for good breastfeeding guidance. And we have seen, because of laziness or whatever, people go and take the donor milk because it's there, instead of calling the mother to say that we need milk now. And that is not the right use of donor milk. In random cases, we support all the children with severe intestinal problems, gastrointestinal problems. Gabriel has been in and out of the hospital all his life, and we were able to support him with milk until he turned 2 years in September this year. It varies to what extent donor milk is being used in other departments, such as the maternity or intensive care for all the 6 children. In my hospital, with the largest milk bank, babies at the postnatal ward can sometimes have a meal or 2 instead of formula until the mother's milk come in. And also sometimes mothers are hospitalized due to operation, or they need to take some medication for a period, and they can also have milk for their baby, even if the baby is healthy. And every infant should receive mother's own milk or donor milk as its first meal. Yes, it's a very bold target, but at least all sick and preterm children should receive it instead of formula. There is simply a lack of resources and willingness to take on the cost of staffing, organizing, and operating milk banks, which can cover a wider need. All parents must give their consent for the use of donor milk. The consent can be given over phone verbally and then later signed. It is not always possible to have the written consent before we start the donor milk. The consent form explains the benefits of using donor milk if mother's own milk is not yet available. It also explains the safety routines and testing of the milk and for bacteria and the donors for viruses. It describes that whoever gives milk should not be able to know who receives it. Conversely, the individual recipient cannot know who the milk comes from, but the milk bank, of course, has this overview. The form ends with a sentence about the alternative to donor milk. It says, breast milk will have a number of nutritional, immune-stimulating, and anti-infection benefits that factory-produced substitutes do not have. Alternatives to breast milk from donors would be cow's milk-based breast milk substitute, which are mixed in water. There are no issues related to parents who are willing to give their consent to have donor milk. Donor milk has been so implemented in the care for preterm infants for so many years, so there is no question or doubt about the use. To achieve good breastfeeding practice, breastfeeding knowledge, and the right level of donor milk usage, we have several activities to promote and support staff. We have the National Resource Center for Breastfeeding, which work on different levels to increase the knowledge and also give advice to authorities. It's a very valuable resource for us working in the field. Bereaved mothers can also donate milk in Norway. The milk is usually pasteurized because we don't have the mother to fill out the same screening form that other mothers have to fill out. And we use the blood tests from the pregnancy. And also usually this milk is pumped for has been in contact with the milk bank, so it's not pumped under the same conditions. So we kind of have simplified the whole process, but we are very willing to take this milk into the milk bank. So is it safe to use raw donor milk? There is no doubt that there are benefits associated with using raw milk. So you need to look at the risks and minimize or eliminate them. We find that milk pumped at home are clean enough and that the donors are so eager to be able to donate to the tiny infants. With precise procedures, good support for the donors, frequent testing of the donors for CMV, and bacteria test of each and every unit of milk, it will be safe. Thank you so much.
Thank you, Anne. It's a pleasure to listen to your experience every time, and I think half of you maybe are using raw milk. Can you raise your hands who uses raw milk? No, it's not half. It's not half, but Norway is a great example for this way to go, and we have not enough time, but maybe one of you can has an urgent question. Heather.
The CMV positive milk, that's also used raw, just from a later age stage. Okay.
We have no time for further questions.